Hello, everyone. What's up? And welcome to episode 2 of A Needle in the Haystack, a behind the scenes account of a mucosal melanoma survivor. I'm Chris White, mucosal melanoma survivor, thriver, advocate, inspirational speaker, and self published author of Killing Cancer with Tills. Today's episode pretty much picks up where the last one left off. This is a little bit of the conversation from my very first appointment with the Mucosal Melanoma Specialist, where I learned exactly what I had and was ready to move forward. Quick disclaimer before we get started, just want to mention that I am not a medical professional. I am not soliciting any medical advice. I am only an expert on my story. If you need any medical attention or advice, please seek your care team.
How are you doing?
Alright, how you doing?
So, I heard your story. I just wanted you to rehash it for me. How did you feel and how things progressed? Just repeat that for me, just to understand it better.
Yeah.
So when did things start?
I don't know, back in May, found this lump,
Mhm.
didn't seem normal, went and got checked out, thought it was a lymph node, said go, take these medications, then go down, I want you to see the surgeon. So the surgeon, he thought it was a femoral hernia, went in for that surgery, he's like, nah, it's just a lymph node, but we took it out, sent it to pathology. Meanwhile, I went to go look at this hemorrhoid, looked at it, he said, no, I don't think it's a hemorrhoid, get your pathology. Got the pathology, saw the oncologist. Oncologist started having me go take a bunch of tests and everything. In the meanwhile, I got had a biopsy surgery removed for the other part that they thought was a hemorrhoid, and more tests, and now I'm here.
Okay.
Yep.
So, you were diagnosed what we call it mucosal melanoma. Okay?
Yeah.
So melanoma is typically known as a skin cancer, which is the most obvious of the skin cancer,
Right.
because it comes from melanocyte. And cancer is always originating from a normal tissue. So it's not a virus, not an infection, it's not anything like that. It's just a normal cells starting to behave wrong. And what they do is they grow without knowing how to stop to grow, and they become mobile, and that's lead to spreading. And those are the two dangerous features of cancer. Mucosal melanoma, it has some features similar to the skin melanoma, but it does not originate from the skin.
Right.
And that gives it different features of that. So, and we'll talk about that in a second. So, though you do have melanoma, but it's not the skin,
Yeah.
and it's not similar entirely to
Yeah.
the smell for that. So, and mucosal melanoma is typically originate from the rectal area,
Yeah.
mimicking a lot hemorrhoids, and that's how it's usually persistent hemorrhoid doesn't go or start
Yeah.
bleeding or start causing obstruction. And females can come around the vaginal area, and a lot of times it also originates from the mucosal areas of the nose and the area around the nose, and
Right.
in those areas. And in the last couple of years, there has been revolution in the treatment of skin melanoma. And mucosal melanoma also has some benefits from those treatments.
Right.
And when we put the treatments for a melanoma, we categorize them into three categories. One is immunotherapy. Drugs that are not necessarily will kill the melanoma, but the drugs that stimulate the immune system to kill melanoma. The advantage of these drugs that when they work, they don't work all the time, but
Yeah.
when they work, they usually work for a long, long time. Sometimes they work forever by means they kill the tumor completely and you never see it again. That's for stage 4, where the patient has his disease metastasized outside the lymph node,
Yeah.
went to the liver, to the lung, etc. So usually stage 4 is always associated with terminal disease, and now we've had that a break and separation,
Yeah.
possibility, opportunity for a break. It's not always like that. The second category is called targeted therapy, and usually target a defect or abnormality in the cancer, scientifically known as a mutation.
Right.
They have certain mutations, there may be some drugs that will target those. So it's a condition to get these drugs only if you have those mutations. This is less relevant to mucosal melanoma, and then to skin melanoma. Although we're still gonna do that because there might be some small benefit from those testing, and we will do that testing to see if your cancer has those defects or have those mutations. Okay. And the most common mutation in the skin is called BRAF, B-R-A-F. It's rarely happening in mucosal melanoma. It does happen sometimes, but even the benefit is not similar to the patients who have skin melanoma. The other mutation is called C-KIT, K-I-T. Okay, and if that has, you have that mutation, then you may benefit from another drugs, and we will talk about that if you have that mutation.
Yeah.
The third category is chemotherapy. And chemotherapy is least effective in terms of skin melanoma. And it does not really make the same impact that the other two categories do.
Right.
That is not necessarily the same with the mucosal melanoma.
Yeah.
Mucosal melanoma seems to be more sensitive to chemotherapy and benefit more from chemotherapy. However, this disease, mucosal melanoma, is aggressive. And chemotherapy does not give you, in general, the long-term benefit that you need. Okay? And I'm talking about stage 4 disease. In a stage 3 disease, where we don't have evidence of disease like yours, we try to take a treatment that works in stage 4 disease and apply it.
Yeah.
Okay?
Okay.
So you don't have, as far as I know, a stage 4 disease. So let's say right now we think that the surgeon took everything out.
Right.
So why you need to see someone like me?
Yeah.
You need to see someone like me because your disease already declared its ability to be mobile. That's why we found it in the lymph node.
Right.
There is a chance that some of these cells are outside even the lymph nodes and somewhere lurking in the body. Could be the liver, could be the other lymph nodes, could be the lungs, could be anywhere. And these cells are small numbers that cannot be seen by PET scan, MRI, or any technology we have. And that also could be not the case.
Right.
Okay, we
Yeah.
don't know. Okay, but this is a very high risk that can happen.
Yeah.
Okay, so you see someone like me because you want to ask me the question. Well, is there something you can do to decrease that risk? And the answer, yes. But there is nothing I can do to eliminate it completely. So, the treatment that we're gonna give you has benefit, but does not have 100% benefit. What I mean, it could benefit you 100%.
Could,
But if I
yeah.
have 100 people like you, not all the 100 will benefit from that.
Right.
That's when I wanna make the difference.
No,
Okay?
I understand.
Okay?
Yeah.
So what are the treatments for that? First of all, I do want you to see one of our surgeons. That's imperative.
Okay.
Because surgery is a skill thing, and we see mucosal melanoma more than anybody else. You can take my knowledge and say my recommendation of the treatment and take it wherever you are. You cannot take the surgeon's hand.
Yeah,
wherever you are.
exactly.
So I do want you to see one of our surgeons. I think you're scheduled to see Dr. Gresham, who's top surgeon, and we'll see what's his opinion if you need to have additional surgery or not. And we're probably gonna also have you see radiation oncology, but I want you to see Dr. Gresham first, have a look to see if he needs to go again or not. And if everything is clear, then probably we will consider radiation therapy. And that radiation is to the local area.
Mm-hmm.
And the ultimate decision to give it or not is in the hands of the radiation oncologist, but
Yeah.
probably we do it to minimize cancer cells to come back in that area. That's meant to locally decrease the risk of coming back.
Okay.
That's only locally.
Yeah.
Okay, it does not affect cancer coming back somewhere else. Okay, but that's important because if it comes back locally and causes a problem, it can be symptomatic. So yes, we do recommend radiation. And again, radiation decreases the risk, it does not eliminate the risk. And when we say local recurrence, it's not that the surgeon didn't do a good job or anything. The surgeons take what they see, they take positive margin just to rinse
exactly.
up. Yet, despite all that, there might be microscopic disease
Right.
outside that thing, and radiation will take care of that.
Okay.
Decrease further the risk. Do you understand that?
Yeah.
Okay. Then it comes to what we do to deal with the rest of the body if there is small cells that cannot be seen.
Right.
And we give you what we call an insurance policy, a treatment at the moment that will decrease that risk of cancer comes back. When we say cancer comes back, it's those microscopic cells there. So it's not really coming back, it's showing up.
Yeah, okay.
It's not like reborn at one point or something.
Yeah.
It's just declaring itself. And the best chance of killing these things when they are unseen or microscopic or small number or whatever we want to call them, the earlier the better, even
Yeah.
if we don't know if they exist or not.
Right.
So as I said, the best treatment for mucosal melanoma, when it's a stage 4, is immunotherapy, okay? But it's delivered about 20% response rate. And it is approved for patients like you to be given as an insurance policy right now.
Right.
So, but when they made that a trial, they combined all melanoma patients, and the vast
Okay.
majority, over 85 of the patients, 85% of the patients, or even 90% of the patients, were skin.
Yeah.
So the true efficacy of giving you immunotherapy alone right now is a questionable.
Yeah.
Okay? We don't know really. But I do want to give it to you.
Yeah.
In addition, in the past, we have given chemotherapy. Okay? Chemotherapy given for 3 or 4 cycles. That will further decrease the risk of cancer comes back. In the past, chemotherapy in all its formulation did not prolong survival. It delayed the cancer comes back only. So that means patients who took chemotherapy or not, they didn't necessarily live longer, but their cancer comes back. However, combining immunotherapy with chemotherapy makes me feel much more optimistic because immunotherapy does prolong survival. And in your case, we are fighting for cure. So every percent is worth the effort.
Yeah.
Okay? The chemotherapy we talk about is consistent with 3 drugs. It's called CVD. Cisplatin, don't try it, I will give you a cisplatin, pemblastin, and dacarbazine. The truth is, dacarbazine is the only FDA drug approved in melanoma. But cisplatin, pemblastin added to it, and it's approved by societies of melanoma as well as NCCN guidelines, and they have higher response rate. And of course, they come with more toxicity.
Right.
You're not going to get chemotherapy forever. If we agree with Shul and you agree to get it, you'll get it once every 3 weeks for 3 or 4 cycles, depends on how much you tolerate that. So overall 9 weeks. 4 cycles, week 0, week 3, week 6, week 9, and it's be done.
Yeah.
And you will recover from that. You're young, and I do recommend that. I do recommend combining a drug called Keytruda or pembrolizumab into the mix. That is your immunotherapy.
Okay.
That's the standard of care. That's what your insurance for sure will approve for that. And that I will give you for 1 year. You'll continue initially every 3 weeks with the chemotherapy, and that's essential. But then we'll continue alone until we achieve 1 year, and hope for the best for that.
Yeah.
Chemotherapy can bring down the immune system, and I'm giving you immunotherapy. Sounds like oxymoron, counterproductive. No. Sometimes, no, I'm explaining it because that's what I'm thinking. This is a short-term chemotherapy, and the immune system will recover. But if there are tumors and they're being killed by the chemotherapy, there is a chance that will complement the immune therapy.
Okay.
Especially if the chemotherapy is giving only for short time. And 9 weeks is considered short time, and it will recover. And there was evidence that combining chemotherapy with immunotherapy can be synergistic or additive. But 1 is 2 or more.
Right.
And we have done it. So we have done it a lot for that. And we will talk about the details and the side effects next time you see me, because I'm not going to initiate that right now. I'm going to have you talk to Dr. Grisham, see if you get radiation. After that, we get to the chemotherapy.
Okay.
With your disease as an aggressive, I will not give you less than that. You're young, and we need to go through that.
Yeah.
The outcomes from that is not, obviously it's not guaranteed, but that's the best chance to get a decreased risk of cancer comes back in this situation.
All right.
All right. and we'll talk more details about the side effects.
Sure,
and,
sure. Okay.
And this treatment, you can get it locally. You don't
Okay.
have to get it here. But for the first year, I do want you to come back here to get the scans,
Yeah.
the restaging, until we really make sure that everything is okay. And after that, we can maybe alternate scans. Where are you from locally?
Plano, up in Dallas. A few hours.
A few hours. Yeah,
Yeah.
you're from Texas.
Yeah.
Still, it's far. Texas is like.
Yeah, it's a big state, but you know,
It's bigger than the
it's just
middle
up in
side.
Dallas,
Yeah,
but
yeah.
yeah.
No, I mean, it's okay, and Dallas has good. You know, we can refer you to. There are good local oncologists there that
Right.
I trust them, and they can follow up with you. You know, so we have to do that. It's fine. Dr. Cowie is one of them. So I think U.S. Oncology or Texas Oncology in Dallas. We can refer you, so you know we'll spare
Yeah.
you the trip here when it's not needed. But the first year is probably every 3 months is doable to come here
Right.
for the scans, and maybe now after that you'll see an oncologist when we
Yeah.
alternate the treatment. However, if the Keytruda, it's every 3 weeks, and that's going to continue beyond the chemotherapy. So
Yeah.
I mean, for the chemotherapy, it's okay maybe to come for 4 times a year, once every 3 weeks, but then it's probably hard to come every 3 weeks for the Keytruda for a year.
Right.
And for that time, we'll find if you find a local oncologist, and we can talk to Dr. Larry Cowie, I think so. Just look his office, look him up. I mean, but you've seen an oncologist, right?
Yeah, I've seen an oncologist.
Okay, so maybe we'll just stick with him, and
Okay.
if you like him,
Sure.
yeah, and we can talk to him
Okay.
and convey that messages.
That's the oncologist.
Yeah, I don't know.
Dr. Lee.
But,
Okay.
yeah, but I think this is where Larry Cowie is also. I think
Okay.
so.
Yeah. that's
I'm not so
oncology.
sure, but it's
Okay.
okay. I mean, we'll definitely give him a call. I think this
Okay.
will be we'll give him our recommendation as well. We'll talk about the logistics
Yeah.
of how we can alternate and come with
Sure.
that, but it should be doable for that.
Okay.
And we'll talk details about the toxicities of this, but this is the 10,000 feet view of the strategy. I would like you to see the surgeon, because that's very important to make sure
Yeah.
that there's no need for another surgery or local, most likely not, but I want him to have a look and see what's going on there. And then we'll have you to see the radiation oncologist. Radiation has to be done here. Also, this is a skill,
Yeah.
and I want it to be done here. And then the treatment I recommend, if your doctor comfortable giving it, then I'm fine that it gets there. And as long as we will work together in that situation.
Should I be seeing a radiologist before it's surgery or
Radiation
anything?
oncologist. Well, I mean, we can, but I just want you to have Dr. Grisham walk
Yeah.
back and see what he would see there, and then you know,
Okay.
probably schedule it in the same day. We can put it to be seen in
Okay.
that week, you know. So and then
Okay.
if they want to do something, then they'll communicate. It's one department. Did your doctor talk to you about radiation or anything like that?
No, they said come down here and see what will happen down here
Yeah.
for these few days, and then figure out everything after that.
Yeah, so that's
afterwards,
the plan. So let's say put the consult for the same
Sure.
week, so he can see that, and we'll take it from there.
Okay.
Alright.
What else for the rest of today? Anything else, or tomorrow, or any other thing, or what's up?
I mean,
Yeah.
pick line. No, well, it's just like because if you're gonna get radiation, it's we labs. We
Labs.
don't have lab. Yeah, definitely we have. You have to obtain labs
Yeah.
from you, and then
Okay.
we'll take it from there. All right.
All right, cool.
Yeah.
Appreciate it.
Are they gonna do another PET scan here now, or?
And then before we start the treatment, we're gonna have a fecal imaging. When is the date of the PET scan?
July 11th.
Yeah, so your insurance will never allow another scan, another PET scan, but we might obtain.
Just wondering after I just had that recent surgery,
Yeah,
if
scan.
he got all of it, if they
Yeah.
want to look at another scan or something,
Not yet. And
No.
it's just that. So
Okay.
we'll get it like in your scan looks good. Okay?
Yeah.
So we don't have evidence of distant disease. We're probably gonna obtain another CAT scan sometime after, if you get radiation after the radiation,
Okay.
and then we will start treatment. Okay.
All right.
So we're looking at treatment not before 6 to 8 weeks
Okay.
to start treatment if we're getting radiation. Okay.
Okay.
And we'll take it from there.
Okay.
Do you have time for a couple
Of
questions?
course, I'm all the for
Okay.
you.
So the diagnosis is mucosal melanoma. It's not stage 4.
No,
but-
not that. We don't have evidence that it is a stage 4 right now. Okay?
So is there a stage that coincides
You know,
with
this is
this?
what we call stage 3 because of the lymph nodes involvement for that. Okay.
Okay,
But this is the inguinal lymph node is it's not in the regional lymph node, so this is advanced stage 3 in that situation.
Okay. And it's a very fast-growing, aggressive
The,
cancer?
the
or is it-
pathologies that we see it is demonstrating that the cancer dividing fast, so when we look into that, yeah.
Okay. And then for treatment, immunotherapy, well, radiation first, and then immunotherapy and chemo? Okay.
If he's getting radiation, I said the final decision in the hands of the radiation oncologist, but I definitely would recommend something.
Okay. So next steps then would be to see the
Radiation oncologist
Okay.
and the surgeon. And we'll see. We'll have to see if you can see them at earlier time points, but I cannot guarantee that. It's just
Yeah. I think I already have an appointment with a surgeon now here.
On the 6th.
yeah.
Yeah.
It's 10 days, yeah. So it's just
Mhm.
like
So
I
he
don't
would
know why
see.
they didn't coordinate that with.
Well, they were gonna try to, but they said that was as soon as they that they could get the surgeon lined up after I saw you.
Yeah, they couldn't get you both at the same time.
Or-
And they said, well, we could just wait and come down and do it all at once, but they felt it was important to at least get this part
That's fine.
first.
I mean, I think
so-
it's okay.
Yeah.
It's I think in that scenario, we can still, you've got the idea of what's the big pictures we need to be
Yeah.
done,
Mhm.
and then we follow up. So we will follow up what's going to happen with the surgeon, and then we'll take it from there. I'm going to probably give you since when you are there, so you're coming on the 6th.
Yeah,
Mhm.
like another week and a half.
Yeah, I will have a phone call. I don't want you to go and come back with
Right.
the situation on the Wednesday after. So it's on the 8th. I'll have a phone call. I'll have by that time motivation will decided to tell you, and we'll have if you have radiation or surgery or additional
Yeah.
surgery, then I'll put an appointment when I'm going to see you for the treatment, and we'll see and consent. We'll start the insurance process, etc., etc., etc. Okay. We will be talking to your doctor also to see if he can capable of delivering the CVD plus Keytruda. Now again, there is no this regimen has never been given together. I have given it for tens of patients already for that. And that's less toxic than what the insurance approved. The insurance may approve something called biochemotherapy. And that's what some of my colleagues use, but that's last decade's treatment. I mean, we use still the chemotherapy, but we use it with the new immunotherapy for that. And I'm more comfortable with this treatment than other treatments for that. Okay?
Okay.
And it's way less toxic. And less toxic doesn't mean it's not beneficial. It's probably more beneficial.
Right.
Okay?
Okay. So the,
So that's why your local doctor may not be heard of it, and he may not be comfortable giving it. But we'll see if we talk to him and he's comfortable with that. If not, then still recommend that you come here to get the chemotherapy.
Sure.
okay. So we're gonna try to get the radiation oncologist and the surgical
We
team
will put the
appointment at
appointment
the
that.
same
Yeah, we'll
time.
try to put them in the same time, so you
Okay.
save you. That should not be a problem.
Okay. And then anything between now and our next visit on August 6th?
No, you'll be fine.
Okay.
Whatever, just you get the pictures. Again, this is not a hopeless situation. The aggressiveness is because the goal we want to achieve is here, and that's what we're going to focus on right now. And of course, there's no guarantee, and this is type of aggressive tumor you have, but this is why we set up an aggressive treatment, and hopefully we can defeat that.
Right. Okay.
And it's going to be long run. I mean, we're going to keep following you for 5 years. Not, the longer we go, we spread the scans. And
Yeah.
the first year is every 3 months or 4 months, and then we go to 6 months, and we go to
Yeah.
1 year, and then you never see making. That's
Okay.
the goal. The goal is never to see making.
Yeah. Okay.
Okay, sounds good.
Okay, sounds good.
Now, I'm sure you're gonna go home and you say, forgot to ask him about that. If it's urgent and you feel like you wanna have